Thank you very much. The next subject we'll be reviewing from last IAS meeting is the subject on virological suppression in children, programmatically transition to pediatric dolutegravir. And my colleague, Professor Ochie Agbaji, we say that the virological suppression in adults is getting close to 95% now, and the suppression in children appears to be lagging behind. Are we able to attribute that to the non-inclusion of dolutegravir in pediatric regimen? What do you think?
Thank you, Prof. To a large extent, there are other factors, many factors can attribute to the lack of achievement of virological suppression among children and adolescents, ranging from the caregivers and side effects of the medications. But inclusion of dolutegravir will definitely be a game changer in achieving virological suppression if all other things are taken care of.
Thank you very much for your perspective. That is very true. But we have data that's actually showing that if DTG, given its characteristic that it's able to sink viral load very fast and sink it deeply, is brought to bear on the antiviral therapy for children, we might be able to bring larger number of children to virological suppression, the way we are experiencing it today among the adults. And the data that is showing that, first of all, came from the Odyssey trial. Odyssey trial, where a sub-study under Odyssey trial included about 85 children weighing less than 14 kilograms. You remember that earlier, in the earlier days of DTG, they did not even allow pregnant women to use DTG. When DTG came on board for treatment of adults, they say there is no correct dosing for the children and the adults who are actually enjoying the very important effect of DTG to the exclusion of children. So it is the very first indication that DTG will be very useful among children was from the Odyssey trial, where 85 children benefit, 85 children weighing less than 14 kilograms with an average age of 6 years were included. And the finding from that Odyssey trial was very, very instructive in the sense that the viral load suppression was not different from what was being experienced among adults. So the question now is, how do we encourage countries to roll out DTG as a first-line regimen for children? And of course, different countries are now coming up with country-specific, experiences. So in Nigeria, I'm happy that we have the USAID working in 2 states in Nigeria, Akwa Ibom State and River State, and they collected this data from over 155 facilities in the 2 states to let us have an idea of what is happening to children that are programmatically switched from lopinavir ritonavir containing regimen to dolutegravir, pediatric dolutegravir containing regimen. In the 2 states, they included over 2,350 children that were all on lopinavir ritonavir based regimen. They primarily switched them to DTG containing regimen, and they follow up these children for a period of 1 year. In that study that was reported by USAID, led by one Dr. Hani, and was presented at IAS meeting in Brisbane in June 2023, they categorized the over 2,000 children into those that had undetectable viral load as at the time they were switched from lopinavir ritonavir containing regimen to DTG containing regimen, about 1,900 of them. And of course, there are those that had what they describe as low-level viremia, which they define in that study as children with viral load between 41 and 999 copies per ml of plasma, and the children that have been shown to fail the lopinavir containing regimen, about 89 of them, and they have viral load 1,000 or more. These children, all of them, this category of children were followed up for a period of 1 year on a pediatric dolutegravir containing regimen. What happened to these children after 1 year of follow-up? Those children that had undetectable viral load, about 81%, if you go back to the previous slide, 81% of children had undetectable viral load. But by 1 year, the proportion of children that became undetectable rose from 81 to 91%, meaning that those people that had what we could call low-level viremia have actually been properly suppressed. They had low-level viremia, and where they were on lopinavir containing regimen, they became suppressed when they were taken to a lopinavir containing regimen. You can now see that the group that had low-level viremia, 14%, 12 months ago, the group with low-level viremia had dropped to 7%. And you have about 89 children that were unsuppressed. That 89 children had become only 51 children, meaning that DTG containing regimen on its own, without initial HIV drug resistance assay, just programmatically switching patients from lopinavir containing regimen to DTG containing regimen, has a higher likelihood of getting a lot more of our children to achieve suppression. But at what cost is this? The drug is not costlier than lopinavir. It is also cheaper, but is it associated with more side effects than lopinavir? No, but the IAS presenters didn't come up, with what are the features of DTG containing toxicity. But we have another in-country study, what we call transitioning of children to optimal regimens of pediatric dolutegravir, the Torpedo study, that actually focused more on if you place a child on the dolutegravir containing regimen, is it at a cost of some toxicity? And this is why this question was raised in that Torpedo study. This question was raised to the caregiver. Have any of your patients on DTG experienced any of the following side effects, and to what extent? And what we take from here is the so-called neurocognitive impairment that may be associated with a virulence-containing regimen was not seen when our patients were placed on a DTG-containing regimen. Bad dreams, lack of sleep, and all this, and hyperactivity, these were not seen. One important complication of lopinavir containing regimen was gastrointestinal side effects, particularly diarrhea. This was not seen when patients were switched to a DTG containing regimen. What we could say was constant side effect, which may actually not be it may be a welcome side effect, if you can put it like that, is they said the child become more active. I don't know whether the child becoming more active is a side effect. That's what you want the children to be able to do anyway. But most children also have what the parent called increased appetite. And in that particular study, although it is not reflected on this slide, is the fact that that increase in appetite was not associated with morbid obesity in the children that were studied in the Torpedo trial. So the essential take-home point from this study is the fact that viremic children on non-dolutegravir containing regimen, even without HIV drug resistant assay, can become suppressed when they are programmatically switched to pediatric dolutegravir-based regimen. That is the point we want to emphasize, and that there's actually fewer side effects, and it's not at an increased cost to our program. I don't know whether you have some perspectives.
No, I think you have said it all. It's just to agree with you that with a programmatic switch to pediatric dolutegravir, there's a lot of benefit in terms of
in the country as a whole, in the country as we speak, I hope our children are all now on PDTG.
Yes.
Or are there still indications for not using pediatric dolutegravir?
Most pediatric children are currently on DTG.
And it's already reflected in the Nigerian antiretroviral treatment program.
Yes.
Thank you very much, Prof.
Thank you, Prof.